I thank the organizers for inviting me and also changing the order a little bit so I can get home for a clinical issue. But today I'm going to take a 40,000-foot view. I think you've seen very nice demonstrations from Dr. Chowsey as well as Dr. Scianti on the use of HIFU here in the U.S. and abroad. And so, you know, as the director of robotic surgery at Cornell, I am and as most urologists who treat prostate cancer are, we are technophiles. And you know, the robotic surgery, which is now ubiquitous, I think is a good example of this. For instance, in 2004, it comprised 1% of all surgical treatments for prostate cancer. Presently, that figure is around 85 to 90%. And we published the first nationwide comparative effectiveness study in JAMA in 2009. And similar to what Dr. Chowsey said about how the press interprets these findings, you know, in our study we showed that there were benefits. However, men were more likely to be diagnosed with erectile dysfunction as well as urinary incontinence. And then the headline here was results improve and robotic surgery wins converts. And so what the controversy surrounding robotic surgery was that it was a more costly form of surgery. It increased the cost, and here you see this example again from the New York Times, where there's mention that prostate cancer is a litmus test for healthcare reform, in that there are different treatments and you see the differences in cost. And we'll come back to this cost equation, I think, which is very important when we take a panoramic view of the treatment of prostate cancer. Having a little challenge with the button here. And so we heard earlier about the advantage of HIFU. It's a transrectal approach at present. I think we're going to hear about some transurethral delivery mechanisms, but there is no incision. So in contrast to the robotic surgery, which I mentioned earlier, this is even more minimally invasive. Just summarizing some of the points that have been made already, there's no incisions, there is spinal or general anesthesia. In contrast to radiation therapy, the majority of radiation therapies, that portion of the body can only tolerate a certain number of dosage, and as far as surgery goes, there is no partial prostatectomy, and so therefore HIFU may be repeated. However, it is considered investigational by some professional societies, and we heard earlier about the tissue ablation approval. And so I'm not going to belabor this point, as Dr. Chowsey has already reviewed the literature very extensively. I will say that in terms of focal therapy, which was already presented very nicely by Dr. Scianti, the premise of this, of course, is the MRI fusion. And I had a chance to do fusion biopsies with Dr. Marks at UCLA, as well as currently here at Cornell. And I think one caveat to this, and for the engineers out there, I think one of the big challenges for prostate cancer present is that multiparametric MRI, the multiparametric MRI rather, is currently only sensitive in about 47% of cases, meaning that when you have prostate cancer there, multiparametric MRI only picks up about half of those prostate cancers. And so that becomes a challenge when we talk about a popular, the popularity of ablation technologies, which is based on your mapping biopsy as well as MRI. And so in a different published outcomes that a London group presented, Hashish Ahmad's group, their 12-month partial gland ablation outcomes were 92% chance of complete urinary continence, 77% preservation of sexual function in men with good baseline urinary and sexual function. On repeat biopsy, there was about 81% of men who had the absence of any clinically significant cancer defined as Gleason 7 or higher. Their Gleason 6 cancers on repeat biopsy, the likelihood was a little higher. In terms of the trifecta, which we talk about in terms of prostate cancer being continent, potent, and cancer-free, that was 54% at 12 months. There was a 5% procedure retreatment rate. And then when we compare this, as mentioned earlier, to radical prostatectomy, again, where you're removing the entire prostate, we heard a little bit about looking at PSA. So your PSA is undetectable because there is no more residual prostate tissue. And this study comes from across the street, or at least my street, Memorial Sloan Kettering, where they looked at different surgeons and the heterogeneity and outcomes of preserving urinary control as well as potency and curing cancer, or your likelihood of being cancer-free by PSA at 5 years. And you can see that the best surgeons were about somewhere around 50%, up to 60% in terms of their trifecta rate. I think the backdrop of this, again, is that the New York Times recently mentioned that up to half of men now with low-risk prostate cancer or choosing no treatment at all, which is active surveillance. And when we go to the National Comprehensive Cancer Network, which is a professional guidelines, we see that for men with very low risk prostate cancer, the features defined there, meaning they have very low volume Gleason 6 disease, if their life expectancy is less than 20 years, active surveillance is a reasonable treatment option. As well for low risk disease, which just means that they have more Gleason 6 disease, if they have less than 10 years of life expectancy, observation is again very reasonable. And then more recently, earlier this year, even for intermediate risk prostate cancer, low volume, active surveillance is reasonable for those with less than 10-year life expectancy. So again, this also illustrates some of the slides that you saw earlier, the difficulty in looking at cancer-specific or overall survivorship at 10 years, because you see here professional guidelines recommending no treatment for some of these prostate cancers. And so finally, what is the value of device registries for stakeholders? So for patients, currently, hasn't been mentioned earlier, but there is no approval again, unfortunately, and so therefore a lot of these men are paying out of pocket, which is $25,000, making them true consumers. There is no consumer guide or consumer reports to help them decide, well, how does this therapy compare to others? Am I a candidate? What are the short and long-term outcomes? And again, I applaud Dr. Scianti and Dr. Chowsey for their work in trying to demonstrate these. And what are the side effects compared to traditional therapies? In terms of again, I apologize. Can we advance to the next slide? There we go. In terms of the device manufacturers, a registry would allow the acquisition of data for a specific indication of prostate cancer from the FDA. This in turn would then allow CMS to issue a CPT code, allowing reimbursement, which would then be followed by payers, and a device registry would capture a lot of these outcomes that are being done in community centers across the country, as well as academic centers, and offer feedback to device manufacturers in terms of quality and outcomes for R&D. Next slide, please. And so finally, or rather for health plans, of course, health plans or insurers are paying for any of these treatments. There's an absence of focal therapy as a comparative treatment at present. Really, HIFU is the first one, which again adds the challenge of looking at the outcomes. One also must consider aggregate costs over time. For instance, there may be a significant cost post-treatment if there are complications that need to be cared for and or crossover to definitive therapy. The private health plans, as I mentioned earlier, will usually follow the lead of CMS, or the Center for Medicaid and Medicare and Medicaid. Next slide, please. So I mentioned earlier the significance of costs, and so in this model, we use time-driven activities-based costing, which is from Michael Porter at the Harvard Medical School, looking at the true costs of healthcare, again, as we shift from fee-for-service to value-based care. And again, it's important to understand the implications of a recurrence of prostate cancer that must be either treated with a repeat HIFU or crossover to definitive therapy. And we can see that if there are a need for repeat therapies, the cost of HIFU over time will exceed upfront cost with definitive therapy. So again, patient selection is very important. Next slide, please. And then for physicians, as I mentioned, most urologists and physicians who treat prostate cancer are technophiles, but we need the data to counsel patients. We need to be smarter about patient selection. There's a lot of heterogeneity in terms of how do you follow these patients over time. For instance, there's mentioned earlier about PSA velocity. However, if you look at the most recent publication of over 5,000 men on active surveillance in 18 countries, PSA is no longer even used as a metric to take someone off of active surveillance. It's actually the presence of clinically significant prostate cancer on biopsy. The data that can be derived from these registries can help us overcome learning curves and so forth. And finally, as I mentioned with the out-of-pocket costs, there is conflict of interest potentially when referring a treatment. Next slide, please. And so I mentioned the learning curve, and frankly, we as surgeons are often criticized by internists and medical oncologists who have randomized trials for their medications. The ideal paradigm was really developed out of Oxford, England, and here you see the various stages for the adoption of a new technology or new procedure. So I would argue that at present with HIFU or partial gland ablation, we're in stage 2B, again, the technique is going to improve over time just like robotic-assisted surgery has, but I think a device registry allows us to do this in a structured fashion. Next slide, please. And so these are some of the data sets that we propose that need to be looked at very carefully. Final slide, please. And so again, I think that in terms of the various stakeholders here, just like a Venn diagram, there's a lot of overlap in terms of the benefits of monitoring and looking at this data very carefully. Thank you for your attention.
Are there any questions? Jim, just given what we're seeing with the relatively low side effect profile given with the technology, and also the slides you showed where there are several groups of prostate cancer patients with certain characteristics that are not recommended to go and undergo treatment, do you see, or how do you answer the concern that this therapy might lead to treatment of men who might not otherwise need to be treated?
Sure. So I think that's a great point, and I'm glad you brought that up. So I do think that there is, you know, what drives men off of active surveillance and or those who initially may not get it. For instance, you may be 50 years young. You do want to preserve quality of life, and or there are men who are in their 70s, for instance, for whom whole gland therapy is going to inevitably lead to a risk of erectile dysfunction or incontinence. And so I think in those men, for instance, there is the treatment of the anxiety because of the uncertainty of whether or not one has clinically significant cancer that may not be detected on MRI or biopsy. I do think HIFU offers that value. And so again, I don't want to seem like I'm nihilistic about the adoption of HIFU. I'm not at all. But I think that we need to take a big picture view of where we are and where we want to go, and I think do this in a thoughtful fashion. I think Steve has a question.
That was a great presentation, and I agree with you. I think stage 2B is probably exactly right. But one of the comments is that I think is a specialist urologist, I think we have to understand that this is early technology in the States, and so there's skill sets required that we haven't learned generally in residency, aren't part of a typical urologic curriculum. And so it's the adoption of the ablation paradigm, understanding image-guided therapy. And so I think we do have some ways to go with that. And I would echo your recommendation. I think we absolutely need data collection, because the only way we're going to understand whether we are making a difference and whether this is a cost-effective approach is exactly that. So that was a really nice job.
Thank you.
Thank you.
Thank you.
Thanks, guys.
Thank you.